Hello everyone. My name is Docsaab and today I am super excited to walk you through a comprehensive review of the ACR-EULAR criteria for rheumatoid arthritis. We are going to dive deep into understanding these really important guidelines, both for how we classify rheumatoid arthritis and how we actually use them in the clinic. Rheumatoid arthritis can be a tricky condition and these criteria have truly been a game changer in helping us manage it effectively. Let's begin with a quick peek at what we will cover. The 2010 ACR Euler criteria really made a big leap forward in how we classify rheumatoid arthritis. They were specifically designed to fix some of the shortcomings of the older guidelines, especially when it came to catching the disease early. These criteria were born from a fantastic team effort aiming to create a standard that everyone around the world could use. They do two important jobs. They help us classify patients precisely for research and they give us great support for diagnosing patient in the clinic. Catching rheumatoid arthritis early is absolutely key to preventing irreversible joint damage and these criteria are fantastic for making that happen. However, it is good to remember that nothing's perfect. For instance, rheumatoid arthritis without those specific autoantibodies can still be a bit of puzzle, and these criteria aren't meant to be the only thing we use for diagnosis. Plus, there are always new stuff happening, like recent updates on risk stratification, which we'll touch on bit later. To really appreciate how significant the 2010 criteria are, we need to take a quick look back in time. There was a clear need for something new because the earlier 1987 ACR criteria had some definite limitation. They often weren't sensitive enough to catch early rheumatoid arthritis, which meant delays in classification and, more importantly, delays in getting people the treatment they needed. At the same time, our understanding of how rheumatoid arthritis develops just exploded. We learned so much about inflammatory cytokines like TNF alpha, interleukin 1, and interleukin 6. This scientific progress really underscored why getting in there early was so crucial to protect those joints. These all led to an amazing collaboration between the American College of Rheumatology or ACR and the European League Against Rheumatism EULAR. They put together a joint working group that went through a three-stage development process, analyzing tons of data and gathering expert opinions from 24 clinicians. All that hard work paid off with the publication of this new criteria in the September 2010, quite an achievement. Alright, let's break down the actual pieces of the 2010 ACR and EULAR criteria. First thing first, for someone to even be considered, they need to have at least one swollen joint, and there shouldn't be any other obvious reason for that swelling. The heart of this criteria is a scoring system. If patient scores 6 or more total points, they are definitely classified as having rheumatoid arthritis. This score is built from four main areas and each one contributes points. These are joint involvement, serology, acute phase reactance, and symptom duration. Don't worry, we are going to dive into each of these in much more detail over the next few slides. Let's start with the joint involvement. This section looks at how many and what kind of joints are affected. Points are given on sliding scale. You get 0 points for just one large joint, then it goes up to 1 point for 2 to 10 large joints. When we get to smaller joints, it's 2 points for 1 to 3 small joints, 3 points for 4 to 10 small joints, and finally a big 5 points for more than 10 joints as long as at least one of them is a small joint. This emphasis on smaller joints really highlights a classic feature of rheumatoid arthritis. Now let's move on to the other three areas: serology, acute phase reactance, and symptom duration. For serology, which covers rheumatoid factor and anti-citrullinated protein antibodies, if both are negative, it's 0 points. If either rheumatoid factor or ACPA is low positive, you get 2 points. And if either is high positive, that's 3 points. These antibodies are really key clues in rheumatoid arthritis. Acute phase reactants like C-reactive protein and erythrocyte sedimentation rate are basically indicators of inflammation. Normal levels mean 0 points, but if your CRP or ESR is abnormal, that adds 1 points to the score. And finally, symptom duration looks at how long symptoms have been sticking around. If they have lasted less than 6 weeks, it's 0 points. But if those symptoms have been there for 6 weeks or longer, you add 1 point, which tells us there is a more established inflammatory process going on. Let's clarify what these criteria are really for and how we use them in the clinic. Their main goal is to create a really consistent group of patients for clinical studies. This is super important for doing good research and developing new treatments. They also help us get people into treatment quickly in our daily practice. While they are not a strict diagnostic rulebook, they often use to back up diagnosis, especially for patients who have inflammatory joint swelling, but it's not clear what's causing it yet. This is critical for starting treatment early and preventing joint damage. It's cool to note that ACR EULAR team doesn't stop at classification. They also set criteria for how we measure disease activity and remission using things like how many tender or swollen joints a patient has and how patients and doctor assess the global impact of the disease. This helps us monitor and guide ongoing patient care. Every set of criteria has its good points and its not so good points, and the ACR EULAR criteria are no different. On the strong side, they are much better at picking up early rheumatoid arthritis with a sensitivity of 0.86 in early disease, which means earlier classification and getting people into treatment faster. They are especially effective for RA that is positive for those autoantibodies, and they give us a really standardized way to approach research. However, some limitations include a lower specificity around 0.050 in early rheumatoid arthritis, which means there is a chance of classifying someone who doesn't actually have rheumatoid arthritis. There is also quite a bit of variability across different studies, and they can sometimes miss many patients with autoantibody negative RA. A really important point is how they are sometimes misused. They are not meant to be the only tool for diagnosis. Plus, if someone gets effective treatment very early, it can sometimes mask the criteria and making classification trickier. Let's really highlight the progress by comparing the older 1987 ACR criteria with our current 2010 ACR EULAR criteria. The 1987 criteria often weren't sensitive enough in early disease, leading to those treatment delays we talk about. They mostly relied on rheumatoid factor and simply counted how many criteria were met. They served their purpose at the time, but as we learn more about rheumatoid arthritis, they become a bit outdated. The 2010 criteria, on the other hand, really shine in early disease, helping us catch that window of opportunity. They include ACPA along with RF, which is super specific, and they bring in those acute phase reactants like ECR and CRP. A big chance is the weighted scoring system, where getting a cumulative score of 6 or more is the decider. This whole framework was the result of an incredible international team effort. The world of rheumatology is always moving forward, and there is definitely an active conversation happening. Is it time to tweak the current criteria again? And guess what? There are indeed new things happening. The Euler and ACR risk stratification criteria for arthralgia were just published in May 2025. The goal here is to spot people who are at risk for rheumatoid arthritis even before they meet the full classification criteria. This really shows how Euler and ACR are continuously working to make their guidelines even better. The future looks exciting. We are definitely heading towards even earlier identification and more proactive ways to manage rheumatoid arthritis. So, to wrap things up, the 2010 ACR and Euler criteria have truly transformed how we manage rheumatoid arthritis by encouraging early identification and intervention, fundamentally improving patient outcomes. Looking ahead, the focus is on ongoing research and updates, aiming for even earlier detection and increasingly personalized treatment plans. We are always striving to give patients with rheumatoid arthritis the very best care possible. Thank you all so much for your attention. I'll be delighted to take any questions you might have now, and if anything else pops up later, feel free to reach out to me via comments. And please like, share, and subscribe to the Docsaab's Diary.